If I was in a room with those negotiators, the first thing I would say is, let me out. I think, and you said the audience doesn't get to make speeches, but we do, I guess. So I'll make a short speech. The thing is, I'm not even sure I'd waste my time trying to be persuasive because I'm not sure that facts matter in this environment. If facts mattered, we wouldn't be doing what we're doing right now, that's for sure, in healthcare. And if there was any sort of scintilla of bipartisanship, we'd be in a very different place. So I could put on a rational hat and say, hey, this is for the good of the country, and this is going to help your constituents, and all those sorts of things, which I believe are true, and yet all those things have been said, and it hasn't really mattered. So I would try and get out of the room.
Okay. So I'm also not going to answer the question. This is a great thing for the panel to say. We're just going to ignore the question. I don't know what to say, quite frankly, to try to convince the panelists that they should support it. But what I think is really interesting and what is so bizarre about what has been happening with all the changes that have happened in the marketplace as a result of not being able to repeal it directly. I'm going to take one example and just play that through. So John talked about one of the things that happened last fall was that the Trump administration decided that they were no longer going to support insurance companies that were participating in the marketplace by paying the cost-sharing subsidy. So historically, the law requires that any individual between 100 and 250% of the federal poverty guidelines gets a premium tax credit. That goes up to 400%. But if you're between 100 and 250%, you get a cost-sharing subsidy that helps reduce the deductibles and the co-insurance and co-pays and make it a more reasonable plan. So it's not so high deductible. When the bill was originally passed, there was no appropriations made for those cost-sharing subsidies. So the Obama administration said, well, it's law that we do it. We're going to just give the insurance companies money, and they found the money to give the insurance companies. There was actually a lawsuit that challenged it. The opponents to it actually won that lawsuit, but it was stayed. And then the Trump administration just said, okay, we're going to no longer give these payments anymore. Now, the insurance companies, I'm looking at Chris because Blue Cross Blue Shield in North Carolina is our insurance company. The insurance companies still were required to give the cost-sharing subsidy. So what did they do in order to be able to afford to give the cost-sharing subsidy?
All right.
They increased the premium rates. That increase increased the federal costs. I think CBO, and I could be wrong in this, so with a grain of salt, I actually have it here and can find it, but I think they estimate that it's going to cost the federal government $190 billion over 10 years by getting rid of the federal payments to the cost-sharing subsidy. That is such a weird idea that eliminating a payment to insurance companies will cost them more than paying it straight out. So all the advocates have been screaming, let's get the cost-sharing subsidies back in. Let's get the cost-sharing subsidies back in, because what happens is when the premiums go up, the amount that the people who have to pay, who get subsidies, doesn't go up. They still pay a percentage of their income, so that stays the same. So when the premium goes up, the federal government pays more money, the individuals don't, for the people who get subsidies. Well, now we're in this situation where the advocates are saying, don't give payments for cost sharing, because what has happened is all the states have loaded that cost sharing subsidy into what's called silver plans, which means that the federal government is giving the individuals more money in subsidies that they can go to purchase whatever plan they want. And if they got cost sharing subsidies back, those premiums would go down and they would have less money to shop. So you're put in this really weird situation. If you care about the people who don't get premium subsidies, you want to give the federal government to give cost-sharing subsidies because the premiums will then go down for everybody. But if you care about the lowest income people, it's actually better the way it is right now. It is such bizarre economics that go on in the ACA. And for any of you who are interested and you go to the reception, you don't understand it, you can come talk to me, you can talk to John, you can talk to Becky, or you can talk to Brendan back there, and we'll explain it in more detail. But it is a very bizarre situation that the ACA puts in, where there's all of these, you think simple fixes, but the unintended consequences are amazing in the bill. So if I was in the room and I could tell them what to do, I don't know what I'd do on cost sharing, but I would definitely do reinsurance.
Okay. I would echo all of that, and I think what I would also say is if you want to try to address health insurance coverage through private insurance, then damn it, you have to offer a stable regulatory environment, because it's extremely risky for insurers to stick their neck out and insure small risk pools, with unpredictable groups of people in terms of what their risk profiles are. They didn't know what their costs were going to be, and if you want them to participate voluntarily in this kind of a scheme which is designed to increase healthcare coverage, then you have to have reinsurance mechanisms. You have to have predictability on what the subsidies will be. And if you're not doing that, then you're not sincere. You're just not sincere. As John said, it's not a question of them not knowing how to do this right. I mean, it's just not wanting to sabotage is what it is, right? And so it's unfortunate, because it could be done. You could do it through private insurance. You could increase coverage through private insurance if you wanted to. So if you're sincerely trying to do so, you could do it. I mean, Romney Care was a Republican idea. What was it, from Heritage originally, right? So, but then you have to be sincere about it, and they're not.
Great, thank you.
Okay. Yes, ma'am.
First of all, introduction. I'm Gina Upchurch. I run a program in Durham, North Carolina called Senior Pharmacist. We help people manage meds, pay for meds. We're the SHIP coordinating site for Durham County, and we do a lot around social determinants of health. And a graduate of this program that led to my program, actually, my master's paper. Thank you, John, Pam. It's been really, y'all are awesome. I have two questions, and I think they're very related. First of all, I love, Sylvia Burwell would talk about the triple aim in sort of her simple terms of saying, population health, improved individual health and quality, and then cost and restricting cost or trying to control cost. It feels like in a lot of the conversation we just had is about coverage, not so much about bringing costs down, and talking about B and D being heavily subsidized with Medicare Part D. So my question is, you look at other countries, we spend twice as much on health care, but when you look at what influences our health, it is those, the housing, the transportation, and, super excited about North Carolina's Medicaid transformation in terms of addressing social determinants. But where's the seriousness around controlling costs? Because I see a lot of middlemen, middle women, middle everybody coming up trying to get a piece of the action. Have the cojones to actually look at cost, and are we really getting value for what we're putting in? Because there are so many people feeding off our healthcare system. That's the first question. And the second question is related, and it has to do with structural racism. You look at states that have Medicaid that have stricter requirements, and they often have more people of color on the Medicaid program. And then you look at states that have more white people, and they have easier to access benefits, more. So I just think that plays into a lot of what we're talking about, structural institutional biases that we're not really getting at. And that also has to do with why we're not addressing social determinants of health. So cost and structural institutional racism and how that's related to the things you're talking about.
Softballs.
What's the question? I'm hard of hearing.
So there are two questions. The first question is about getting serious about bringing down healthcare costs, right? How are we going to do that? Can we get serious about doing that? Can we pay for value as opposed to quantity? The second question is about structural racism and the impact of putting additional responsibilities on people who get access to Medicaid and how that works in different states with different demographics.
So I'm going to start by talking about cost, because I am going to quote a wise sage who comes and talks in my class, Stuart Altman, who's right here, who talked about how when the ACA was passed, you couldn't take it all on. when the ACA was passed, if you had gone in and said that you were going to deal with cutting provider payments, actually this comes from both of my sages over here, both John and Stuart, that if you were going to talk about cutting provider payments, initially you would never have gotten the ACA passed. And so you needed to deal with coverage first, and then you could deal with cost. And in fact, if you look, and you know, Gina, if you look at the Medicare program, when the Medicare program was passed, they promised everybody everything. They said, we will pay you whatever you got before, we're going to give it to you. And it wasn't until it was in place and it was there for, sort of the buy-in was there, that they could then go in and do some of the things they've done in the Medicare program to bring down costs. So you know all the things that they've tried in the ACA. John and I can debate this a little bit. I'm a little bit more optimistic. He's a little bit more pessimistic about whether ACOs and bundled payments are going to make a difference or not. I don't think we've got a solution. I don't think there's a magic bullet unless we come up with a global budget, but not a budget that says we'll cut Medicaid, but we'll leave everything else there, because that has so many unintended consequences. And that's what they were actually talking about. So it's sort of interesting. I am totally in favor of a global budget if we're talking about the whole healthcare system, and I am totally opposed to a global budget if you're talking about a component of the healthcare system, because all it does is push the cost somewhere else, and it discriminates against that particular group of people. And I don't think we're ready, absent a Medicare for all, to talk about a global budget. And we've had some of those discussions about whether you can do it as part of a multi-payer system or not. As to your equity issue and your racism issue, I think it's the same thing as essentially saying it's a deserving versus a non-deserving. And I agree with you.
So on the cost side, I think the problem the United States has with cost control is that cost control is ultimately income control. A dollar of healthcare spending is a dollar of income to doctors and hospitals and insurers and the medical device manufacturers and everybody. And nobody wants to give up a dollar of income. So it's difficult politically to do, and we in the United States have been unwilling and or unable to do what they do in Canada and Japan and in virtually all of Europe, which is set universal fee schedules, have global budgets, and reduce administrative costs either through a single payer or through coordinated purchasing by multiple payers. We just have not been able to do that. Politically, there is good news, which is the rate of growth in healthcare spending in the United States has been fairly modest for most of the last decade. And part of that is due to the Affordable Care Act, not to ACOs and bundled payments, but to other things. So that's good news. The problem is it's a rate of growth that's modest on such a high base. And because we're moving towards high deductible plans and higher copays, so many Americans are paying more out of their own pocket. So if you ask people, they don't think rate of growth in healthcare spending is slowing. And that's because for a lot of people, it isn't. Just briefly on race, there is some evidence from the public opinion literature that, the states that have not expanded Medicaid are not random states.
That's right.
And to Pam's point, when you're talking about expanding Medicaid, it's a question of expanding Medicaid for a other population. Who is the other population in those states? And there is a relationship between the percentage of a state that is African American and white opinion on Medicaid expansion and whether a state expands.
Can I ask a follow-up to that? So is there ever a reason, or is there ever a situation in which Medicaid programs should be trying to help people into employment?
Yeah, the issue is not whether you help them into employment, and in fact, under the old administration, they supported efforts to help people gain employment. The question is whether you attach Medicaid eligibility to it. So it was Indiana, I think, that first applied for a waiver that would have required that people work or be in work-related activities, and CMS said, no, you can't do that. But if you want to offer employment-related activities to them to help them move up and get into employment, you can do that. So yeah, sure.
But you could also see it from the other side, which is if you cut people off from healthcare completely, won't that make it harder for them to find a job because their health will deteriorate? So you probably hurt employment by cutting people off, making it conditional on work rather than.
Yeah, which is why they delink them in tandem. Yes, sir.
Hi, my name is Jason DeBruin. I'm a healthcare news reporter. I wonder, do you think that public policy around the Affordable Care Act, or public policy opinion, I apologize, would be different if at the outset at the exchanges, insurance companies had set the initial premiums far higher and then had to simply reduce them because they had more money, as opposed to setting them, what I might argue is artificially low, and then had to, of course, raise premiums year after year? Because, I mean, I'm in the media, so it's sort of an easy story to say that Blue Cross is raising ACA premiums by, double-digit percentage points, and then that creates, obviously a backlash because costs are going up. When at the end of the day, the costs that individuals actually pay are not overly burdensome. I mean, they're $70 or $80 potentially for many people, not everybody, but for many people. So the question is, do you think that we would be having a completely different discussion if, in fact, Blue Cross and others would have set the initial premium higher and then been able to reduce it or at least keep it the same year after year?
I actually think it would only make a marginal difference. I do understand the point you're making because every year that we talk about a 10% or a 15 or a 20% rate increase, and that is a problem from a public perception. But I actually think the harder thing, and having higher premiums would actually make it worse, is the cost sharing that you've got. Because there are many fewer people the cost sharing subsidies are much less robust than the premium assistance subsidies are. So if you set those premiums higher to begin with, you would have had higher deductibles, higher co-insurance, higher co-pays. I think you may have had fewer people enter the marketplace early on if those premiums were higher. I don't know that, but I don't know that I think that's the bigger dissatisfaction, not the premiums.
Yeah, I mean, I agree with what Pam said, and Jason, I think the other point is to ask, what is the relationship between public opinion and reality? And the fact of the matter is that public opinion on the Affordable Care Act, until the attempt to repeal it, was very, very stable, actually, for 8 years. It barely budged for 8 years, no matter what happened. And so it may be that if the premiums had been set higher initially, as you're suggesting, and they were, off the top of my head, I think the premiums were about 20% lower than expected the first year out. If they had set them 20% higher, maybe we would have had more negative stories in 2013, 2014 on the premiums, and maybe the negative stories would have went down, as you're suggesting, over time. But a lot of the public opinion is actually operating on a sort of different wavelength. And to Pam's point, I don't think there's a very big percentage of the American public, excluding our students who are here today, who understand that most of the people in the marketplaces aren't actually paying higher premiums. They're just getting more subsidies and their premiums aren't going up. That's not well understood, and it's very difficult to communicate.
Hi, my name is Frank Ryder. I work for American Institutes for Research, and I'm actually entitled a Human Services Financing Specialist. So I spend a lot of time thinking about Medicaid, Medicare, private insurance, and so on, especially for children and youth, and particularly in the context of behavioral health. But my question is really for Benjamin, and it's about the financing options that the study panel is going to look at. When we saw a modest increase in healthcare costs in recent years, I would assert some of that is because of the availability of preventive care at no cost to people, the encouragement for folks to see doctors before they're really, really sick. And so our society has been paying for the cost of our health system failures for many years in terms of court systems, law enforcement, prisons, loss of productivity. I'm wondering if the study panel, and I know, Jonathan, that people only run for office every 2 to 4 years, so they don't really have a very strategic horizon, our political leaders. But will the study panel be looking at some of the opportunities to redirect spending from paying for the cost of our failures more upfront to some of these strengthening social support, preventive, and early intervention opportunities?
Well, actually, it's interesting you bring it up because we just finished a study panel last year that was on social determinants of health, which was precisely, well, very much not as broad as you framed it, but focusing on how the Medicaid program could be freed up to collaborate more with other social services to prevent healthcare problems from either emerging or becoming more severe than they would otherwise be. And so that's certainly an important issue. I think our study panel has its plate full already with the design issues that I outlined, so I don't think they'll be addressing social determinants or the more systemic issues that you raised. Although you're absolutely right. I mean, the healthcare inequality dynamics are a big driver of and malnutrition and diabetes. We have so many issues that make us different from the typical OECD country, whether in Europe or Asia or Canada, that are driving our healthcare costs and our poor health outcomes. It's not just our healthcare financing system or our healthcare system.
In the blue.
My name is Stephanie Schaft. I'm a billing services supervisor for UNC Healthcare, and my staff spends a lot of time explaining to patients the difference between what their healthcare costs and what their insurance is actually going to pay. So what do you all think should be done to increase public education that would change that public opinion?
And then there's charges.
Question.
So the question is, what should be done on the public education side to change public opinion about healthcare?
Well, is that what you're asking?
Yes. What kind of public education should be given to allow the regular people, not the people in this room who study this, but regular people to understand the difference between their healthcare costs and what they're paying for their insurance premiums? Because a lot of times people say, I pay $2,000 a month for my premium, why do I have to pay a $5,000 deductible?
That's a great question. I want to know why they have to pay a $5,000 deductible.
Exactly.
I mean, there's lots of efforts to try to educate consumers about our crazy healthcare system, but it goes to the point that we have a crazy healthcare system that makes no sense to anybody. So I don't know how you explain that as long as we have a system. If you went to a Medicare for all, if you got subsidies like what John was talking about, where you actually provided meaningful subsidies for cost sharing, I don't understand. I mean, I've been teaching at the School of Public Health since '97. I used to talk about the Walmart greeters who had health insurance back in the 90s, but they had a $1,000 deductible, and I thought that's basically the same as not having any deductible at all.
Exactly.
Now it's $1,000 is a great policy, but the Walmart person is still making $11 or $10 or $9 an hour.
Yeah.
I think it's ridiculous what's happened, and I have no idea how you answer that question. So,
I mean, part of it is to develop, if you had and I'm not advocating for this, so at the Academy, we don't advocate for specific policies, but if you had a uniform policy across our entire healthcare system, a uniform method of insuring people, then public opinion would develop around how it works. People would talk to each other in their civic associations and when they're playing golf or playing, shuffleboard or whatever they do with other people, they would all have a certain common level of knowledge about how the system works. They could form opinions about it, and they could then try to change things that aren't working. But we have such a balkanized system with so many that nobody really knows. I mean, my employee healthcare is different from, your employee healthcare. Everyone's plan is different, and so we can't even talk to each other about it. So we'll much less have a political party have a campaign platform that would, in a simple to understand way, change the way the deductibles are determined.
I mean, I just want to add in one other point. Everybody talks about transparency. I still haven't figured out how transparency actually works. And if you're in a billing office, you know it. So Blue Cross Blue Shield has, in the marketplace, has probably 4 or 6 different policies. UNC's part of their different policies, but depending on which tier they are, they're going to be covered by it at a 70% or a 90% or whatever it is. So how much do you tell that patient? How do you create a website that is available to tell everybody the prices for all different things when there are multitudes of policies out there, and what a person has to pay is dependent on which policy they buy and which carrier they're under.
There is nothing about the finance of American hospitals that makes sense. We're talking about monopoly money here. There's nothing that makes sense from the time you go in to what insurers do, to what hospitals charge, to what different hospitals charge in the same area, to the explanation of benefits that I get that I have no clue what they are, and I'll probably bring my next one to Pam. There's nothing that makes sense. I think the point that Pam and Ben are both getting to is how do you understand something that's not understandable? And that's what we have.
Yes, sir.
So, Pam, you, in almost a throwaway, at the very end of your talk, talked about the possibility of the state of North Carolina going into Medicaid if it'd be willing to take a waiver. Now, let me go, I want to turn that around and say that may have been the most important statement that was made today. In the following sense, my sense about the battle over the Affordable Care Act was less about the exchanges and more about what the Affordable Care Act fundamentally did to Medicaid. And it split the country in ways that I didn't understand, and I thought I understood it. And that is that you have a large percentage of subpopulations that really were totally opposed to making Medicaid a social insurance program available to all. And we didn't realize that until the Congress went to repeal, and they skipped right over it and went back to the basic Medicaid program and said, we're going to block grants and we're going to do away with the 1965 law. So I would suggest the two of you get together, because when you gave your presentation, you left out Medicaid, and Medicaid turns out to be one of the real sticking points of the Affordable Care Act. We make a lot of noise, and rightly so, about the exchanges, but the conservatives hate what we did in Medicaid. I think it was a great idea. So, going to your issue, if the only way we are going to get those populations that you were talking about onto the Medicaid program is to give some ground, I know you'll have to do it with holding your nose, but if we think that the North Carolina should have an expanded Medicaid program and the other 18 states, we may have to do what you just said. So I'd like you to explain a little more, because how do we do that doesn't really fundamentally break the whole Medicaid program?
So this is really funny, Stuart. My daughter works at the National Health Law Program, which is that organization that I mentioned was bringing the lawsuit. She's not a lawyer yet. She wants to be a lawyer, but she is in there. So we're having this debate going back and forth because they're the ones who brought the lawsuit to challenge this. And I was saying, but it may be the only way we get Medicaid expansion in North Carolina. We have to plug our nose, and if you believe in Medicaid expansion, which I do, because we have 400,000 people or so who have no way of getting any kind of health coverage because they're not eligible for subsidies because of the way the ACA law was written, that I might be willing to plug my nose in order to have work requirements. The problem is, so I'm wavering now. The problem is.
Wavering.
Yeah, right, exactly. Not intended, no pun intended. John would have said that with pun intended, but not me. The problem is that the states that are moving, there are more states that have already expanded Medicaid than have not expanded Medicaid that are trying to do work requirements. There are more states, and they're not doing it just for the expansion population, they're doing it for the traditional Medicaid population. So the question is, in North Carolina, it would do more good than harm. Nationally, it may do more harm than good.
Interesting.
So I am now rethinking my position on whether that is a worthwhile trade-off, depending on whether I'm wearing the North Carolina hat or the U.S. hat.
How many states do you think would move away? I mean, we wouldn't in Massachusetts.
There are 3 states that have already gotten waivers and 7 states that have applied for waivers. Kentucky already had, they were approved. Indiana.
Away with it. Yeah, they're going to change.
No, Indiana, Kentucky, and Arkansas were the first 3 that got it approved, and all 3 of them are states that already have Medicaid expansion. And I'm not sure, even though I know the Kentucky governor hates it, I'm not sure he could get rid of Medicaid expansion.
Well, I mean, to me, it only makes sense where there's going to be expansion, because what are you going to have, children work, or seniors on the?
No, you're gonna have the parents who are 39% of the federal
women,
poverty guidelines.
mothers.
Or fathers,
Because if it's not an expansion state, you're talking about mothers,
or
right?
fathers, or
Very clear,
parents.
yeah.
I mean, there's no longer a requirement that it be a single
Right,
parent anymore,
right.
but, yeah.
Sorry. Yes, sir.
Well, let me ask my question first, because I always get to ask the question. And that is, why don't we look at the cost of medical education and the balkanization of American medicine? We have 5 tiers of provider training. Now, let me tell you who I am. I'm a physician. I did health policy and management at Harvard, and I got interested because I had trained in Quebec, where there's no there's no tuition at medical schools. And I came to Harvard, and everybody seemed to be in debt. And it's only gotten worse since then. And let me just give you some numbers. I mean, we spend 50% of what the world spends on healthcare.
That's right.
Right? I mean, and we spend more than 10 of the next countries. And we have the highest cost and highest medical tuition in the world. Right? There may be a correlation. And if we apply the principles of single payer to medical education, we could create a uniform, more cohesive workforce. And physicians are responsible for 80% of whole healthcare costs because they write prescriptions, right? And then you would have a social contract, and then if the medical education was free, and our physicians are burning out because of debt, there's unprecedented rates of burnout, suicide, and I was in this room when UNC doctors and doctors from University of Utah were saying they were writing opiate prescriptions because they wanted to get, evaluations that would keep their job stable because they're in debt. And there was a forum at Duke, I hate to say it, but the people came to the conclusion at that forum that the only way you would solve the opiate problem is if you had a single payer. We have degraded our medical workforce. There was an article that came out of Princeton University from the NBER that showed the lower ranked your medical school is, the more likely you are to write opiate prescriptions. And if you're from a Caribbean medical school or an osteopath medical school, it's really the highest. And virtually anybody can become a healthcare provider in this country and write a prescription for opiates.
Thank you, sir. Can I just have them answer the question now?
Well, I mean, but nobody, in 37 years, everybody wants to, charge more money for medical tuition, and you're getting
Super fair point. And I think the cost of medical education is an enormous.
And you could solve this problem with, we spend $10 billion a year in medical education.
Okay. So I think the point that the gentleman is making is that the cost of medical education is,
I just didn't hear what he said.
And then,
Him, unfortunately.
do the folks on the panel want to respond to how we can work to bring down the cost of medical education?
Well, you were looking at it.
Well, I think it makes sense. I mean, I don't know any other country that charges this much. I mean, most places it's free, I think. It's certainly a good place to start. I think it's a problem in general with our educational system, right? I mean, I don't know about how John feels about political science PhDs, but they're pretty expensive, aren't they?
It costs much more than they're worth.
But, no, in general, I mean, I think student loans in general drives all American college graduates to become more commercialized in their approach to their careers than they would otherwise. And it's true of medicine, and it's true of across the board. Right, you can't go work for a nonprofit when you graduate from college because, and then you take instead of working for, Bridgespan, you work for Bain or whatever. And it affects our society in many ways. But certainly, that's one way to reduce healthcare costs. It's a clear way. Obviously, it's not the only driver of our healthcare costs. Pharmaceutical costs are a bigger driver probably. But what would you?
I mean, look, the costs of medical education are prohibitive, and it affects what our medical students go into. And, if you're graduating with $150,000, $200,000, $250,000 of debt, and you're considering a career in family medicine versus a specialty. I think it's a good point, and it matters. And to your point about what other countries do, it's sort of as part of that package.
All right, I have time for one more question. Yes, ma'am.
think about, we talked a lot about bipartisanship and like the future for healthcare reform, and I just was wondering, how do you guys see like the efforts of bipartisanship play out over the next few years? We talked a lot about that being necessary, but not how you guys envision that actually playing out like in the legislature and in future healthcare policies.
So I missed the first part.
question.
So the young woman was asking about the future of bipartisanship and how partisanship and bipartisanship will play out with healthcare policy over the next several years and decades. And John, since I know you spoke directly to this and said we haven't been as partisan as we have, and compared it to the Civil War, can you start?
I think the short-term future of bipartisanship is bleak. I mean, I don't want to end on a bleak note, so maybe Pam or Ben will say something more positive. So I think, our recent history of bipartisanship has been virtually non-existent, and I don't think we have had essentially a 10 years war over Obamacare at the federal level, and in many cases at the state level. I don't think it's over yet. Now, a year or 2, 3 years from now, it may be different, and we got to the point where we almost had at least a modicum of bipartisanship on some of the market stabilization, and maybe something like that will come back again. But in terms of big bipartisanship, I don't think we're there. In fact, I think there's a chance in 2020 that rather than bipartisanship, I think the polarization could actually go further. Because I think the Democratic Party is going to nominate somebody with positions on healthcare to the left of where the Democratic Party has been. But that doesn't mean a couple years out that the conditions won't be there. And maybe as the ACA is not going away, so maybe as the ACA stumbles forward, we'll eventually get to the point where a white flag or a yellow flag, or I don't really follow NASCAR even though I live in North Carolina, some kind of flag goes up and people say, okay, we're going to stop making this an existential debate, and instead the parties will work on repairing it and strengthening it and trying to get their own vision of reform. I don't think we're quite there yet.
So this is where I'll be a little bit Pollyannish. I think it's going to depend on the 2018 election. And I think it depends on whether you can flip a House in Congress, whether it's either the Senate or the House. And in North Carolina, I think it depends on whether you can get past the veto-proof margins. Because in North Carolina, both in the Senate and the House, the Republicans control, they have such a large supermajority that there is nothing that the governor, who is a different party, can do, because if he vetoes something, they'll just override it. Once you get to the point where there is some bipartisan structure where either one of the bodies is a different party, or the governor in North Carolina is Democratic, and you can't override every single veto because you don't have a supermajority in both bodies, it creates a different dynamic where there potentially has to be some compromise to get anything done. So that's one way we could get Medicaid expansion through in North Carolina, is if the governor says, I won't pass anything else you want, I will veto everything, and you won't be able to override it unless you're willing to come to the table. That also could happen at the national level if you could flip a House. But as long as you've got it the way it is right now, where you've got supermajorities in North Carolina and the Democratic governor, or you've got all the same party at the national level, you don't have to be bipartisan. You don't have to work across the aisle.
Yeah, I mean, I would agree with all that. I am pessimistic on healthcare as well because of all the vested interests and because it's such a useful wedge issue. And all the stuff from Cambridge Analytica that came out in recent weeks kind of reinforces the value of kind of scaring people in irrational ways. But one issue that I am optimistic about, and something that the Academy is working on, is long-term care. I think long-term care is an issue that is a bipartisan issue, should be a bipartisan issue, will eventually become one. We all have parents and grandparents, and we all
getting older.
We'll hopefully get older. It beats the alternative, is right. So I think eventually you'll see this country come around trying to develop a long-term care policy to deal with the aging of the boomer population, and that is, that's certainly a bipartisan issue. I don't think that could be something that brings us together down the road.
The cost, though.
Thank you. Well, as I've been saying to folks since Saturday, I can't worry about it. The kids will save us. So thank you very much for coming to today's panel. We very much appreciated the attendance. It was great attendance. Please join me in thanking our panelists for their great observations.